Hello everyone, this is Dr. Sam and this video is about shoulder ultrasound reporting. You will learn how to write ultrasound reports regarding shoulder pathologies. The reports will include the findings, impression, and recommendations. We will start with a normal shoulder ultrasound report. These are the clinical indications in this example. Right shoulder pain with limited range of motion. No history of trauma. Suspected rotator cuff pathology. After the clinical indication, technique is written. A comprehensive ultrasound examination of the right shoulder was performed using a high-frequency linear transducer. Multiple views including longitudinal, transverse, and oblique planes were obtained. These are the findings, starting with rotator cuff. The 4 rotator cuff tendons are scanned. Supraspinatus tendon, normal thickness and echo texture, no evidence of tear or tendinosis. The same statement is written for infraspinatus tendon, subscapularis tendon, and teres minor tendon. After the rotator cuff, you can write about the biceps tendon, long head of biceps tendon, located in bicipital groove, normal thickness and echo texture, no evidence of tenosynovitis or subluxation. Then you can write about the subacromial subdeltoid bursa. The bursa is of normal size with no evidence of fluid collection or bursal thickening. Followed by glenohumeral joint, normal joint space with no evidence of effusion. The cartilage and labrum are unremarkable. Acromioclavicular joint, normal joint space with no evidence of hypertrophy, fluid collection or degeneration. Then you can write about soft tissues, no evidence of soft tissue masses or abnormal fluid collections. Deltoid muscle appears normal. You can also write about bone structures, no cortical irregularities or bony abnormalities detected. The acromion and clavicle are of normal morphology. This is the impression of a normal shoulder ultrasound report. Normal ultrasound examination of the right shoulder, no sonographic evidence of rotator cuff tear, tendinosis, or other pathologies. You can also write this section called recommendations. It includes statements such as clinical correlation and referrals or recommending additional imaging modalities. Now we will look at pathologies, starting with supraspinatus tendinosis. The clinical indication in this example is right shoulder pain with limited range of motion, no history of trauma. These are the findings of the rotator cuff. Supraspinatus tendon demonstrates hypoechoic and heterogeneous areas within the tendon substance. There is a loss of the normal fibrillar structure consistent with tendinosis. No evidence of a full thickness or partial thickness tear. The rest of the rotator cuff tendons were normal. The long head of biceps was located in the bicipital groove, normal in thickness and echo texture. The subacromial subdeltoid bursa was also normal. The glenohumeral joint, acromioclavicular joint, soft tissues and bone structures were normal. And here is the impression. Findings are consistent with Supraspinatus Tendinosis, characterized by hypoechoic and heterogeneous areas and loss of fibrillar structure within the tendon. No evidence of rotator cuff tear or other significant pathology. Clinical correlation is recommended. Consider physical therapy and anti-inflammatory medications. MRI may be considered if symptoms persist or to further evaluate the extent of tendinopathy. This is a case of full-thickness supraspinatus tear. The clinical indication is same, limited range of motion, and no history of trauma. Due to repetition, I have removed the normal findings of the shoulder structures. Only the pathological findings are written, so those normal findings will be the same as the findings shown earlier. They are excluded. Here are the findings. Supraspinatus tendon. There is an anechoic area of discontinuity involving the entire thickness of the tendon, indicative of a full thickness tear. The surrounding tendon appears hypoechoic and heterogeneous with loss of normal fibrillar structure. This is the impression, full thickness tear of the supraspinatus tendon, characterized by an anechoic area of discontinuity involving the entire thickness of the tendon, no evidence of additional rotator cuff tears or significant pathologies. Clinical correlation is recommended and a referral to an orthopedic specialist is advised, and MRI is also recommended. Now we have a case of a partial thickness supraspinatus tear. The clinical history can be same for many shoulder pathologies. This is the finding in the supraspinatus tendon. A partial thickness tear is noted on the bursal side at the anterior aspect of the supraspinatus tendon. The tear is characterized by a focal hypoechoic area disrupting the tendon fibers. The remainder of the tendon shows normal echo texture with no evidence of full thickness tear. So this is a partial thickness bursal side tear. This is the impression, partial thickness bursal side tear of the supraspinatus tendon at the anterior aspect. No evidence of additional rotator cuff tears or significant pathologies. This is a report for a partial thickness tear on the articular side of the supraspinatus tendon. The tear is characterized by a focal hypoechoic area disrupting the tendon fibers. The remainder of the tendon shows normal echo texture with no evidence of a full thickness tear. This is the impression, partial thickness articular side tear of the supraspinatus tendon near its insertion on the humerus. No evidence of additional rotator cuff tears or significant pathologies. This is an intrasubstance partial thickness supraspinatus tear. These are the findings in the supraspinatus tendon. An intrasubstance tear is noted near the greater tuberosity of the humerus. The tear is characterized by a focal hypoechoic area within the tendon fibers, which does not extend to either the bursal side or the articular side of the tendon. The remainder of the tendon shows normal echo texture with no evidence of a full thickness tear. This is the impression, partial thickness intrasubstance tear of the supraspinatus tendon near the greater tuberosity. not involving the bursal or articular sides. This report is of a partial thickness supraspinatus rim rent tear. These are the findings. A partial thickness rim rent tear is noted at the insertional footplate of the greater tuberosity. The tear is characterized by a focal hypoechoic area at the insertion site, disrupting the tendon fibers. The remainder of the tendon shows normal echo texture with no evidence of a full thickness tear. This is the impression, partial thickness rim rent tear of the supraspinatus tendon at the insertional footplate of the greater tuberosity. No evidence of additional rotator cuff tears or significant pathologies. This is a case of subacromial bursitis. There is evidence of subacromial bursitis. The bursa is enlarged with hypoechoic fluid collection. The bursal walls are thickened and there is hyperemia noted on Doppler imaging, indicative of inflammation. This is the impression, subacromial bursitis characterized by an enlarged bursa with fluid collection and thickened bursal walls. Now we have a report of calcific tendinitis. These are the findings in the supraspinatus tendon. There is evidence of calcific tendinitis. A hyperechoic calcification is observed within the supraspinatus tendon, measuring approximately 8 millimeters in diameter. There is no disruption of the tendon fibers, and the surrounding tendon appears mildly thickened with signs of tendinosis. This is the impression, calcific tendinitis of the supraspinatus tendon characterized by hyperechoic calcification within the tendon, mild tendinosis of the supraspinatus tendon. This is a report for Biceps Tenosynovitis. These are the findings. Long head of biceps tendon. There is evidence of tenosynovitis. The tendon is located within the bicipital groove. It appears thickened with surrounding hypoechoic fluid collection, indicative of tenosynovitis. Doppler imaging shows increased vascularity around the tendon sheath, confirming inflammation. The tendon itself remains intact with no signs of tear. This is the impression, biceps tenosynovitis characterized by thickening of the long head of the biceps tendon and surrounding fluid with increased vascularity. Clinical correlation is recommended. Consider anti-inflammatory medications and physical therapy. Ultrasound-guided corticosteroid injection may be considered if symptoms persist. This is a report for biceps tendon tear. The long head of biceps tendon. There is a partial thickness tear of the long head of the biceps tendon. An anechoic area of discontinuity is observed. There is associated fluid collection within the bicipital groove. No evidence of tenosynovitis or subluxation. And here is the impression, partial thickness tear of the long head of the biceps tendon, associated fluid collection within the bicipital groove. No evidence of rotator cuff tears or additional significant pathologies. This is a case of biceps tendon rupture. Clinical indication, right shoulder pain with weakness. Here are the findings. There is evidence of a complete rupture of the long head of the biceps tendon. The tendon is not visualized in the bicipital groove, consistent with a full thickness rupture and retraction. The proximal end of the tendon is retracted, and there is a hypoechoic area corresponding to the empty groove. Increased fluid is present within the bicipital groove, indicative of a hemarthrosis or reactive synovitis. This is the impression: complete rupture of the long head of the biceps tendon with proximal retraction, associated fluid collection within the bicipital groove, no evidence of rotator cuff tears or additional significant pathologies. This is a report for biceps tendon subluxation. Clinical indication is right shoulder pain with a history of instability. These are the findings: long head of biceps tendon. There is evidence of subluxation. The long head of the biceps tendon is partially displaced from the bicipital groove. The tendon lies partially outside the groove. The tendon itself shows normal echo texture without evidence of tear. There is a small amount of fluid surrounding the tendon, consistent with mild tenosynovitis. The transverse humeral ligament appears intact but may be lax. This is the impression: subluxation of the long head of the biceps tendon with mild surrounding tenosynovitis. No evidence of biceps tendon tear or additional significant pathologies. Clinical correlation is recommended, and other recommendations include physical therapy and orthopedic consultation. This is a report for biceps tendon dislocation. These are the findings. There is evidence of dislocation in the long head of biceps tendon. The long head of biceps tendon is completely displaced from the bicipital groove. The tendon is visualized medially outside its normal position. The tendon itself shows normal echo texture without evidence of tear. There is a minimal amount of fluid within the bicipital groove, consistent with reactive synovitis. The transverse humeral ligament appears disrupted, contributing to the instability. This is the impression: complete dislocation of the long head of the biceps tendon with medial displacement, disruption of the transverse humeral ligament, associated reactive synovitis within the bicipital groove, no evidence of biceps tendon tear or additional significant pathologies. Now we have acromioclavicular joint osteoarthritis. These are the findings in the AC joint. Joint space, narrowed joint space with irregularity of the articular surfaces, osteophytes, presence of small osteophytes at the joint margins. Effusion, mild joint effusion is noted. Synovitis, thickening of the joint capsule and synovium consistent with synovitis. Soft tissues, adjacent soft tissues show no abnormal masses or significant fluid collections. This is the impression: acromioclavicular joint osteoarthritis characterized by joint space narrowing, articular surface irregularity, and osteophyte formation. Mild joint effusion and synovitis, no evidence of rotator cuff tears or additional significant pathologies. This is a case of AC joint cyst associated with a supraspinatus tear. There is a full thickness tear involving the supraspinatus tendon near its insertion on the greater tuberosity. The tear measures approximately 1.2 centimeters in width. Subacromial subdeltoid bursa, mild fluid collection noted within the bursa, suggestive of bursitis. Cyst. There is a well-defined anechoic cystic structure located at the acromioclavicular joint. The cyst measures approximately 1 into 1.2 centimeters. Joint space. The acromioclavicular joint shows mild widening. Effusion. Mild joint effusion is noted. Associated findings. The cyst appears to be in continuity with the underlying full-thickness supraspinatus tendon tear. In the subacromial subdeltoid bursa, mild fluid collection is noted, suggestive of bursitis. This is the impression: acromioclavicular joint cyst associated with a full-thickness supraspinatus tendon tear, mild acromioclavicular joint effusion, subacromial subdeltoid bursitis. This is a report for glenohumeral joint effusion. There is a significant accumulation of anechoic fluid within the glenohumeral joint. The fluid collection measures approximately 1.5 into 1 centimeter. Synovium, mild synovial thickening is noted, suggestive of synovitis. Cartilage and labrum, both structures are visualized and appear normal without evidence of tear or degeneration. This is the impression: glenohumeral joint effusion with associated mild synovitis. No evidence of rotator cuff tears or additional significant pathologies. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.